Although we acknowledge the necessity and the benefits of this plan, how about the actual costs, both in terms of time for the person being assessed and the practice that that person works in, as well as the cost of having enough people around our country to this increased level of practice?
Those are big questions, important questions. We're going to have to work through those very carefully. As I said, it's reassuring that colleges such as the obstetricians and gynecologists have done that. They currently costed at $1,500 direct costs. Now there are indirect costs in behind that, of course, and those have also got to be accepted. The issue around the number of people that are required to do this comes back to how frequently it's done, and the fact that one might be involved in this, either having it done oneself or doing a review, say 3 times in 5 to 7 years. I think though, given that we have shortages in many specialties in New Zealand, clearly that is going to take people out of practice for that time. And I think it is one of those areas which we're saying, let's put the emphasis on quality here, even if we're trading off some quantity. That is, if we're going to maintain the standard of our service, then sometimes we have to say that there is going to be a delay in actually providing that treatment. We're trading off, to a degree, quantity against preserving quality.
However, John, there's always going to be a cost to the individual being assessed, and if it's an extra cost to what the individual is currently paying, there will be some opposition to this. And as you said, you mentioned a trade-off about not going to a conference and the same cost to have an assessment. How about the fact that we seem to have the same people go to conferences, the same people interested in their own professional development, happy to fork out the money, whereas really some of the people that you may want to be assessing and encouraging greater personal development are those people you never see anywhere.
Right. And I think this comes back to the other purpose of this. I mean, I would put the emphasis on the fact that this is a benefit to the whole profession, but clearly there are people, a very small percentage I would suggest, who are not actually up to standard in their practice and not making the effort with their continuing professional development that they should. And I think this function, this performance assessment, will help identify that group and will enable a plan to be set in place to try and get them up to speed.
Because the Medical Association always worries about, as does Ron Patterson, those practitioners who are relatively isolated. And it's not always rural practitioners, but some people who are in a scarce specialty, working even in large areas, they don't have great peer support. They're the people that are probably, might suggest, more likely to have a greater need for what you're suggesting. And I just want to make sure that you've thought of a way that you will actually capture them as you might capture those that are performing well.
Yes, I mean clearly they have to be involved, and those who are not affiliated with college, general registrants who are not in a training program, would be people that we would want to involve in the system very early on. Most of the predictors of those who don't perform well, who are isolated and have various risk factors, they're not sufficiently specific for us to say, let's go and do that group first. Because even in that group, there's a pretty small percentage you're actually not performing up to standard. So I think it has to be across the whole profession.
You touched there on those people who aren't members of a college, and as you're aware, within the general practice fraternity, there are a large number of newly arrived general practitioners who are either not vocationally registered or not even members of the college. So they are a particular group that somebody needs to be embracing in this system.
That's right, and the College of General Practitioners has talked more and more about involving that group in their own CPD activities, and we're hoping that there'll be another accredited CPD provider who will be able to take on that group as well, so that Council can move to a situation where we require every practitioner to be either in a training program or part of an accredited CPD program.
Do you intend to involve district health boards in assisting you with the way that practice visits might flow out? And bearing in mind that a large number of doctors are employed solely by the district health board, and many have joint employment in the private world as well as in the public system. And then in rural New Zealand, particularly in general practice, the DHBs play a great role in interacting with the doctors of the area. Do you see yourself and the council seeking support from district health boards for these practice visits?
Yes, I mean district health boards are going to need to be involved because they've got people from outside the district health board coming in to do an assessment. The other issue that we've got to think through very carefully is that the credentialing processes that all the hospital doctors go through are being strengthened, and what we don't want is two parallel systems that are duplicating each other. We've got to look at where the overlap is and make sure that that is kept to an absolute minimum. I mean, it may be that a credentialing visit can be set up to act as the performance assessment.
Have you or the various colleges that will be involved in this thought about the need to provide locum services, particularly for those solo doctors who might have to take a whole day out of their practice when they're the only practitioner in the area or in the specialty while they go through this practice visit?
Well, it's a difficult one. I mean, given that all solo practitioners have time away from their practice, I think we have to look at the means that they're using currently and see how they can be used for performance assessments as well.
So John, you see these as a learning exercise for the doctors involved, and I would suggest that this is part of their commitment to professionalism, that if we join the medical fraternity, it's a complicated learning exercise throughout life. So if this assists doctors to go along that pathway of learning throughout their career, then this should be seen as a positive move by our doctors.
Yes, I think that's absolutely right. I mean, I as a practitioner, I think it would be useful for me to have two colleagues come on a water run with me, sit in on my outpatients, and point out to me all the things that my registrar wouldn't. That might well be very important for my practice.